Welcome to this explainer, where we're going to tackle a seriously high-stakes medical mystery involving the heart's electrical system, sustained ventricular tachycardia. The heart is a pretty remarkable organ, but when its intricate electrical pathways go awry, the consequences are immediate, severe, and they require absolute decisive action.
Okay, let's dive right in. Imagine the heart's finely tuned electrical grid is suddenly hijacked, firing at dangerously rapid speeds. It's like a runaway train. We really need to understand the mechanics behind this chaos, how to spot it on an ECG, and the advanced tools we use to stop it dead in its tracks. So here is our clinical roadmap for today. We'll be navigating through 1. The tachycardia threat, 2. The great imposter, 3. Emergency acute management, 4. VT in structural disease, and finally, 5. The idiopathic anomaly.
Let's start with number 1, the tachycardia threat, defining the culprit.
To solve our mystery, we first need to definitively identify our main suspect. The crucial point here is that this specific, uniform pattern on an ECG tells us exactly where and how the heart is misfiring. Sustained means it lasts longer than 30 seconds, or it's so unstable it requires an immediate medical intervention. And monomorphic? Well, that means every single QRS complex looks exactly the same from beat to beat. This uniformity is a massive clue. It tells us the electrical signal is repeatedly exiting from a fixed, localized arrhythmia circuit, or a single focal point in the ventricles. We have to understand the massive human stakes involved here. Depending on the heart rate and the patient's underlying heart function, the presentation varies wildly, from mere palpitations to severe hypotension. If left unchecked, this runaway rhythm can rapidly deteriorate into ventricular fibrillation and sudden cardiac arrest. It is quite literally a race against the clock. Moving right along to section 2, the great imposter, VT versus SVT. Now the plot thickens a bit here because we have a lookalike condition that tries to trick emergency physicians. When trying to differentiate true VT from supraventricular tachycardia with aberrancy, you're looking for the absolute smoking gun, VA dissociation. See, SVT originates above the ventricles, but if a patient has abnormal conduction, it mimics VT perfectly. However, if you look closely and see the atria firing at a completely independent, usually slower rate than the rapid ventricles, boom, you have proven VA dissociation. That essentially confirms it's VT. A patient's history is honestly just as revealing as their ECG. If someone has known structural heart disease, especially a prior large myocardial infarction, and they present with a wide complex rhythm, you must assume the culprit is VT until proven otherwise. And morphological clues, like the complete absence of an RS complex in the precordial leads, V1 to V6, that virtually locks in the diagnosis. All right, on to section 3, emergency acute management, stopping the train. When the patient hits the ER, we have to act fast and follow a strict investigative protocol. These steps distill complex advanced cardiac life support guidelines into a rapid response checklist. Step 1 is always assessing hemodynamic stability. Unstable, with impaired consciousness or severe hypotension, we immediately perform a synchronized electrical cardioversion to reset the heart. But if they're stable, we can give intravenous adenosine a shot. Surprisingly, while adenosine is a classic SVT treatment, it can actually act as a diagnostic tool here to unmask the underlying rhythm. If it truly is VT and they have underlying heart disease, intravenous amiodarone becomes our drug of choice to halt it.
Let's shift gears to section 4, VT in structural disease, the scarred heart.
Let's see how this builds when we examine VT in a heart that's already suffered structural damage. Old scars from heart attacks or fibrous tissue from non-ischemic cardiomyopathies act like anatomical traps. As the heart heals, it forms patchy replacement fibrosis. Electricity doesn't conduct normally through those scars. Instead, the signals are forced to navigate around them, creating a dangerous, endless loop, a reentrance circuit. What's truly terrifying is that this VT can emerge years after the initial heart damage occurred, bringing with it a very, very high risk for sudden cardiac death. And this brings us to our ultimate weapon, implantable cardioverter defibrillators, or ICDs. For patients who survive an episode of hemodynamically significant sustained VT related to a scarred heart, an ICD acts as a permanent internal safety net. The data is absolutely clear on this. Studies show these devices lower arrhythmic deaths by a staggering 50% in this patient population, compared to just using antiarrhythmic drugs alone.
Looking at our progression of countermeasures, we move from immediate IV drugs to stabilize the rhythm right up to a permanent ICD safety net. But while an ICD saves lives, receiving a shock is incredibly traumatic, both physically and psychologically. If a patient starts experiencing recurrent shocks because the VT just keeps returning, we don't just sit back and watch. We escalate. We move to catheter ablation, literally mapping and burning away that specific scarred circuit to stop the shocks from happening in the first place.
Finally, Section 5, the idiopathic anomaly, the structurally normal heart.
Just when we think we have all the rules figured out, we find our final suspect. It's a surprising twist, really. This dramatic-looking VT is actually quite benign compared to its scarred counterpart. We call it idiopathic VT, and it happens in patients with totally normal cardiac MRIs and normal heart function. It's often triggered by exercise or a sudden spike in sympathetic tone. The vast majority of these originate from a very specific area, the right ventricular outflow tract. And because the heart is structurally sound, sudden death is exceedingly rare, so these patients generally do not require an ICD.
Because this anomaly comes from a tiny localized focal point rather than a massive, complex scar network, it is incredibly responsive to treatment. If medications like beta blockers don't do the trick, or if the patient just prefers a permanent fix, we can actually cure it. Catheter ablation has an overall success rate of 80% for this type of VT. We effectively neutralize that specific hyperactive spot and return the patient to a completely normal life. Now, as we look toward the future, our interventions are becoming almost science fiction. Experimental techniques like non-invasive stereotactic body radiation therapy, which is technology classically used for targeting tumors, are now being tested to beam radiation directly into the heart scar tissue, stopping VT without a single incision. It leaves us with a provocative question: how long until we can cure the most lethal cardiac arrhythmias without ever even touching the patient? Thank you so much for joining me on this deep dive through the electrical mysteries of the heart.